Hi everyone, today the topic of discussion is the shoulder joint, which is very important joint in our body, not only for the movement, and you see this freeness of the movement makes the human being superior to the other human being. So today I shall discuss this joint. Now you see this is the model of the shoulder joint, where you will see this is the head of the humerus, this is the scapula, this is the attached clavicle, this is the acromial end of the clavicle, and here you will see the head and the glenoid cavity is completely covered by the capsular ligaments. So what are the bones that forms the shoulder joint? You see the glenoid, you see the glenoid of the scapula, this is the glenoid of the scapula, and this is the head of the humerus. Now this head of the humerus is rounded, and you see this does not fit completely with the glenoid cavity. The glenoid cavity is shallow, and it is certainly depend by a small fibrocartilaginous structure which is known as the glenoidal labrum. You will see here this is the glenoidal labrum. So there is partial deepening of the shoulder joint. Now this glenohumeral joint, it makes the major part of the shoulder joint, but other joint also takes part in this formation of the shoulder joint and its free movement, that is the acromioclavicular joint, the scapulothoracic joint, and also you will see the subacromial space. So these are the other features of the joint. Now the glenohumeral joint, you will see when the joint between the two bones are there, you will see there are some articular capsule. Now what is the attachment of the articular capsule? You will see it is at the glenoidal margin of the scapula. In the upper part it will include the supraglenoid tubercle, and in the lower part it will exclude the infraglenoid tubercle. So it is like a rim, but there is a depression just below the supraglenoid tubercle. Similarly, the other end of the capsule is attached along the anatomical neck of the humerus, and in front you see there is a groove, and there is the gap here because a tendon that is known as the long head of the biceps passing this groove that is known as the bicipital groove. Now there is a gap. Next, this capsular ligament, it descends downwards and medially, and there is looseness of the capsule, and this capsule again it follows the anatomical neck of the humerus. So this is the capsular attachment of the glenohumeral joint. If I make it a certain, see, suppose this is the capsular ligament. If you place it here, the capsular ligament, and it is attached other end to the glenoid cavity. So this is the look. You cannot see the whole of the joint. It is covered by capsule, which is the whitish fibrous tissue. And there are thickening of the capsule you will see, which strengthens the joint, that is the 3 glenohumeral ligament. Here you will see the 3 glenohumeral ligament, the superior, the middle, and the inferior glenohumeral ligament. Now you look at this, the X-ray of the glenohumeral joint or the shoulder joint. You will see here, this is the glenoid of the scapula, this is the head of the humerus, and this is the shoulder joint line. How this line is produced? Because you know the articular hyaline cartilage covering the glenoid and articular hyaline cartilage covering the head of the humerus does not cast any shadow. That's why this joint space is formed. So this is in the adapted condition. You will see this is the glenohumeral joint. and you see there is slight rotation here, and where you will see the head of the humerus is rotated laterally. So this view is more prominent here. So this is the X-ray picture of the joint. Now you cannot see the joint when you will see the whole of the body. Now in the body, when you dissect the pectoral region, so you will see this thing is the region of the clavipectoral fascia, which is covered by the pectoral, this major muscle, and this is the clavicular head of the pectoralis major. So in front it is related with the pectoralis major muscle, pectoralis minor muscle, the anterior fibers of this delta shaped muscle, which is known as the deltoid, because all of you know here the intramuscular injection is given, and below you will see here there is the short head of the biceps, and posteriorly you will see here this is the biceps, how it comes, that is the long head of the biceps. It produces a protection to this shoulder joint. Now I will tell you what are the different movements of the shoulder joint. Now before I am describing the different movements of the shoulder joint, you will see laterally it is related with the deltoid muscle, posteriorly it is also related with the deltoid muscle, posterior fiber of the deltoid, and also by the long head of the triceps, and this muscle is known as the latissimus dorsi muscle. So this is the relation of the shoulder joint. Now the important thing, you should know what is the arterial supply of the joint. The arterial supply, there is medial circumflex humeral and the lateral circumflex humeral artery which supply this joint. So you will see here the nerve supply, that means sensation of the joint, by which you can see there is the joint pain, or otherwise if there is any dislocation of the joint or displacement of the joint, you will get the joint pain, and that is joint is supplied by the axillary nerve from below, suprascapular nerve from above, and in front this is also supplied by the musculocutaneous nerve. So this is the nerve supply of the joint. Now I have to discuss about the movement of the joint, which is very important. Now what are the movements of the joint? In the transverse axis, that means the axis passes through the head of the humerus, that is the transverse axis. In this transverse axis, the movements are flexion, that means the carrying the arm forwards and medially, and extension, that is the carrying the arm backwards and laterally. In the physiotherapy, they say this is the horizontal flexion. So they pull the shoulder joint forwards. So this is the flexion and extension. You see the flexion is much more free than the extension. Extension is limited. Then the important movement is that abduction. Abduction means carrying the arm, that is the laterally. How far one can carry the arm laterally? You will see the carry occurs up to the 90 degree. And after the 90 degree, there is actually you will feel that there is arm is locked by the coracoacromial large. At that time, you will take back the humerus, rotate the scapula, and then you can abduct up to your shoulder. So this abduction is not only done by the deltoid done up to 90 degree. After that there is the rotation of the scapula. So for each 15 degree rotation of the humerus, there are 5-degree rotation of the scapula. In this way, the abduction is more free. Next is the adduction. Adduction means carrying the arm from the lateral to the medial aspect. So abduction is more, but adduction is less. Then the combination of all the movement, that is, you should know, before that you should know what is the rotational movement. If I pass a stick from head up to the lower aspect, the rotation occurs in this manner. There is medial rotation, there is lateral rotation. So you will see the medial rotation is more and the lateral rotation is less. And you will see that the circumduction, it is the combination of flexion, extension, medial rotation, lateral rotation, abduction and adduction. And in this circumduction position, you always see the bowler will throw the ball to the batsman. So these are the movement of the shoulder joint. Now what are the muscles forming the movement of the joint? You see here the muscle form the making the movement of the joint. In front you will see that is the pectoralis major muscle. Which fiber? The fiber that is the clavicular fiber of the pectoralis major and the anterior fiber of the deltoid. The extension, that is the extension will done by the posterior fiber of the deltoid and also by the latissimus dorsi muscle and the long head of the triceps muscle. So this is the extension. Now abduction is done mainly by the muscle which is known as the deltoid muscle. You see this deltoid, and this produces the abduction. The first 5-degree abduction is done by the supraspinatus muscle. You look here, this is the back of the scapula, this is the supraspinatus muscle. It goes in this fashion and ultimately it is attached here. You see, from here the supraspinatus go and attached in the fuses with the capsular ligament. Next you will see the infraspinatus muscle. Again it goes from here and fuses in this region. And another muscle you will see, that muscle is known as the teres minor muscle. From where from it arises? It arises from the lateral border of the scapula and fuses with the shoulder joint. You will see this is the teres minor muscle. And anteriorly we will look, this is another muscle, very thick muscle you will see during the dissection of the axilla, and this is known as the subscapularis. So all these muscles, supraspinatus, infraspinatus, teres minor and the subscapularis, it forms a strong bondage over the shoulder joint, and that makes the stability of the shoulder joint, and the muscle is known as the rotator cuff muscle. So this finishes the shoulder joint. Now the clinical anatomy of this joint. Why this joint is so important. Now sometimes this ligament in this joint, you see the ligament here you see this ligament become loose and lax from the by birth, or there may be torn of this ligament. So what will happen? There is recurrent dislocation of this shoulder joint. That means how? There is recurrent dislocation that fits into the cavity, but here sometimes there is this coming out in this position. So in this dislocation the movement is restricted. This is common in in case of some throwing the ball who has got weak, but they are then actually not taken in the cricket team. So this condition is known as the recurrent dislocation of the shoulder joint. And one should say that these people should not run after the bus, or they will hold in the upper part. They should not be go in the crowded bus, otherwise their hand will be automatically come down and there may be some danger. So this is the recurrent dislocation of the shoulder. The dislocation of the shoulder is also common, that is the inferior dislocation. Those who are climbing a tree and after that there is a sudden fall and there may be the dislocation. Another thing is very common for the common public and also by the doctors and the physiotherapists. That condition is known as the frozen shoulder. So this thing is usually seen particularly in the female in the age group of 40 to 60 years. But this thing also happen in case of tailor who doing the hand work, who is sewing with hand. So the cervical spondylosis and frozen shoulder is very common. Where you will see there is the initial movement of abduction is free, but when it moves away, so there is restriction of the movement. The person cannot wear, the female cannot wear a blouse or thing. They have to change the dress also. They cannot do the comb the hair. So this is known as the frozen shoulder. So thank you everyone for watching this video.